Our guest this morning is Dr. Davji Atellah. He is the National General Secretary of the Kenya Medical Practitioners, Pharmacists and Dentists Union, KMPDU. He's here with us. Good morning.
Good morning to you, Latif.
How are you doing?
I'm doing fine. And
Good to see you, Dr.
Thank you.
It's good to see. Now, we have new governments all over the country. From the 47 counties, we've seen the people who've been given the docket of health. You've seen at the national level, the person who's been given the docket of health. First of all, right off the bat, your comments on the various nominees, appointees now?
I think the first thing I will take is to congratulate her for being nominated and vetted and confirmed and actually sworn in yesterday as the CS for Health. And she's coming at a time that there's a lot of expectation from healthcare workers. There's a lot of expectation from the public to have working healthcare, and there's a lot that the previous CS has done, given that he worked at a time when there was COVID-19 pandemic, and therefore lots of this functionality in public healthcare was exposed at the time. So we have a time that we foresee a new government, a new manifesto, and therefore she has to just start the work running and involve stakeholders and actually make healthcare accessible to Kenyans.
Nairobi County has somebody who's also an experienced person in especially matters of advocating for health and health issues, Dr. Anastasia.
Narita. Yes, I think that's. I also want to really congratulate her for that position and for the appointment. One thing that we have seen over time is that when you've been advocating for healthcare for a particular time, you've been in need to have a promotion, preventive, and investment in healthcare. So it is good that the governor of Nairobi, Sakaja, has appointed her to be in that position to actually now implement those things that she has been advocating for. And a lot of times there's always success because then he knows these things, and when he advises the governor, is based on the technical know that he has experienced over time. So I believe with collaborations, we are going to see another what we saw during Dr. Oluga in NMS, where we had a lot of facilities that were constructed in the country, and even a lot of healthcare workers were employed at the time. So for that to progress now with this new regime, I believe there will be much change, given that we have somebody who has been advocating for the same better healthcare. Yes.
And then our conversation today is about the issue of looking at pandemics and looking at research that's done in the country, research that ought to be done to tackle future pandemics. Last week, we visited the Kilifi, where the Kemri Wellcome Trust research facility there. And we talked to the various researchers. We went through to the labs and the various programs that they're running. And my goodness, I mean, we were just awed. City wasn't. He knew about it. But the two of us were like, wow. What? This happens in the country.
I mean, so it's a shock. It was a shocker, obviously. So then the question is, if that's the lay of the, land, what kind of a situation are we really in? You know, from a healthcare perspective, how do you see it, and how should it be?
If you talk about the research, and there's one saying that says there are better data, better decisions, and better outcome. And many times when decisions are made without research, then that's when we tend to just be up probabilities. And that's why if you look at the aspect of the COVID pandemic that came in, we saw a different evolution even in the field of research, where within a year or so, we had vaccines, and we had different studies that were coming out based on COVID-19. And one thing that we must attribute to the WHO and to the Global Research Network is that they were identified. They had already data of pathogens that who could easily cause pandemic in the country or in the world. So at the point that there was COVID-19, they only now had an extra to have action into getting vaccine and getting into action. I think that's what now needs also to be looked down into the countries and down even into the county governments, where research is given the priority into mitigation on healthcare matters. We only have currently in the country KEMRI for human research and cultural for the livestock. But as it is the information that they get and the research outcomes that they have is not laid down into the facilities for implementation. And again, their level of operations have only been put to national government or centrally. But for research to be more effective, there's need to have community involvement, because then they understand why these things are happening and why they have to continue having them. And that's the only way to curb lots of spread and outbreak that we are seeing. Because it is not a very good thing in this country that 70 years after independence, we still see malaria outbreaks that occur over a period and actually people die from it. We still see cholera outbreaks that claim lives in the country. These, if a robust research and planning is put into place, they can actually be combated. And therefore, there's need to not only have KEMRI or CARO, there's need to empower the counties and even up to the facility levels that there's continuous research. We have universities in this country who have a lot of time, very many specialists and researchers. But because lack of funding, none of these countries have active ongoing researchers, to the point that many of the donors that are collaborating currently they're only doing strongly with Aga Khan. So there's really need that the government policies that are being made into place prioritize and put research as a big aspect.
I can understand the lack of funding aspect, but is the broader picture then in terms of priority listing, that then research into some of these things is not really given a priority, and so that's going to trickle down into the funding, that we don't really grasp, from that level, the importance of having this done. You see what I mean?
Yes.
Isn't that the bigger umbrella issue, that because it is not ranked as a priority, then of course the funding issue will come later, because I don't see it as important. The likelihood of me attaching then a budget for it at that level then is much lower.
If I say that, if you look at it clearly, how the research has been and what to be done, for us to have a robust research in the country, there's need to have that also there's trust. And when you talk about global research and global trust, you must have the researchers understanding what they're doing, and they must bring it down to be understood by the political leaders and the policymakers. And then that becomes a conversation that is able to be implemented. If we keep on, for example, in this country now, we've been talking about the dysfunction of public health care. And we do not have data that shows that which facilities, like for now out of pandemic, for example, in level 5s in the country, that do they work? Are the deaths that occur in these hospitals normal deaths? Are they normal? What is the cause? What is causing them? When we have referrals, what is making them to be referrals? When we have people going to having chronic conditions that have not been managed as appropriately, what is making it not to work? But when we have data that is digitalized, that can be shared out, and that can make decisions both in the parliament and in all environment, then we are going to have a different change of mindset in our mitigation.
Yeah, making it sound like we don't have a way of collecting the data, or a way of passing up the data, and a way of interrogating this data. I thought we have a health information management system that goes all the way down to a health facility that then brings the information up to a national level.
We do have DHIS on almost over the sub-counties and every counties, but the aspect of being used in the decision making to determine the path or the direction that the country is taking from the grassroots, from the counties up, is not there.
So we have the data, but now the data is useless if we are not able to use it.
We are not. I think the collection aspect of it, because then it's very important that this data that is collected, the decision on it and the discussion starts from the community. So that means if we're collecting data for any issues, we need to have these people informed of the data that are being collected, then the use of that particular data. So as for the DHIS data, it's there, yes, on prospect research systems, but now on its use to really determine the outcomes and to determine the plans of the country has not been there. And that's why we see a rather divergent action between the KEMRI, between CARO, and even between the counties on their response to issues.
Actually, the question that I'd like to ask, I believe you studied in this country, didn't you?
Yes, I did.
You went to medical school in this country. Yes. Now tell me, when you were in the university, how much research, let me backtrack, how much emphasis do our institutions of higher learning put actually on research? That's question number one. How much of our GDP does the government allocate to research? I'm asking this question for a very simple reason. It's rhetorical. If you look at the so-called developed world, there's a very direct correlation with the amount of money or the percentage of the GDP that country allocates to research and their development. Whether it's US, China, Germany, Japan, just look at it. Now, if ours is at what, 0.8?
Yes.
Okay. Now, that is what may be allocated, but is it easy to access? And does it go to the level where it should be? Because if someone doesn't understand the value of research, and that, as you correctly put it, the decisions that are made are not supported by research findings, then how exactly or what position would we argue or say that we have given research in our lives, and yet it's critical?
Yeah, I think that's actually really very important. And when you look down into one of the complaints that we got from the universities, public universities, we have what you call the Consultants Forum, where we have a sitting with different medical consultants from different countries, from different facilities. Now we have one from Mo University, and they'll tell you that they have a lot of there are a lot of research that they would love to do and feel that they will have to cover, but then there's no that support, because these researchers need fundings and they need quick response from the institutions, from Nairobi University and from even more university. The lack of that support and lack of that framework, they've all now depending on Aga Khan to give them sub-grant for them to do their researches. So that means that the institutions that will actually be doing continuous researches are not empowered to do them. The other aspect is when we put research as the point of making the decision, then it's very easier to mitigate any of those particular outbreaks or any conditions that are being followed. But that's what is lacking in our system.
You know, there's something that happened in this country a while back, when it came to HIV care and treatment. Like with all things new, there's a process that people follow, and with the time it is hoped it will be improved upon. And the only improvement that can actually be made and which is lasting, again, is if that improvement is supported by research findings. Okay? There was a time when you needed to have a certain level of what you call viral load for you to be put on ARVs.
Yep. Mm-hmm.
What they'd give you, broad-based antibiotic, multivitamins, and wait and to see how you stabilize. Then they realized this wasn't quite working because simply the way the disease was spreading and everything about it. So there was a research that was conducted. It was called the Sustainable East African Research on Community Health. It was supposed to be Kenya, Uganda, Tanzania, but it only happened in Kenya and Uganda, Western Uganda, Kenya. Now, that particular study is what proved the concept for testing and treating, meaning what we now take for granted. You test someone, they're positive, you put them on treatment.
Start on treatment.
Immediately. There's no ifs and buts. But it was a process. Now, it was done here, in this country and in Uganda. So wherever you say it is actually being actioned, you can proudly say, actually, we participated in that process. When Kilifi, we talked to scientists who are involved in the testing of some of these vaccines. They were part and parcel of that group, and they're still working on it. Now, but those fundings are not from the country. And yet the people who are conducting that research, which means they have the capacity, are locals.
Yes.
So, when you, as an organization that has a very, very key role in ensuring that the healthcare service provision in this country should be on an upward trajectory of improvement, what pressure do you put on the government to ensure that this all-important aspect of our life, that is research, is actually given the priority it deserves?
And that's why I'm pretty happy that as a union now, we are looking into a prospect that we do not just come with decisions. Like the government just need, just to make radical decisions, but they need to have data and facts based on the action they're making. And for this to happen, then there's to be a stronger empowerment into the research and to involve the scientists. One thing that we are seeing, we proposed to the political leaders during the campaign period that we need to have regulations on the research, because the donors from different parts of the world would have a function like AMPATH or any of these running organizations. They will mine the data and have the information regarding a particular, maybe a disease pattern, disease trends, and then the government actually will buy that data from them because they have not invested in that particular process. So there's actual need to really invest and put a set percentage of the budgeting into the part of research. And not only that, also there's also need to have this information exchange that the experts that we say are from the different developed world, or rather I would say call it global south, collaborate and share the information with the local ones from the initial aspect of the research, so that the information on healthcare that is produced also help the locals in the mitigation of disease. Yes.
How much more advocacy needs to happen to make sure that even members of parliament, as they scrutinize budget proposals, as they pass budgets, they understand the importance of research and allocation towards research?
If you look back into 2020 when COVID-19 came up and there was clinical trials that was to be done. There were doctors from France who said that the first doses need to be given to developing countries. And this elicited a lot of reaction from lots of the populace in the world regarding the same. But the intention, in fact, those doctors had to apologize, but the intention was just to involve these countries in the developing world, rather the southern countries, so that they can be part of the process. Because you cannot be an expert or a scientist to be in the process of clinical trials when your cohort or your people are not part of the samples.
Yeah.
And the whole thing became a little bit political based on, I think, the previous injustices. But that was happening because of the misinformation. Ideally, we need to have all the persons, the population, the public, the communities, and the political leaders understand that what will the outcome of this research help us in. If today, the way we had seen in the pandemic, COVID-19, that is out of the research that had been in existence prior to the pandemic, that made it possible to get vaccines within a shortest period of time.
Yes.
Because they had what's called head start for the process. It's the same thing if we have been having these continuous outbreaks of malaria in the country. The research that has, I think there's been now trials of the vaccines to make it for the malaria.
Yep.
That will ensure that the outbreaks that we continue seeing in the parts of Nyanza and Western actually stopped. So that makes every person understand, and it makes the health committee and the politicians to actually see the need to allocate funds for it.
I don't think they'll see the need, for as long as all this research that we're talking about, the advances that have been made, are currently donor funded. So there's always that assumption that, we are doing all these trials in the country. We've got all these research institutions. We're in collaboration. There's a complete disconnect between research and funding. Because there's understanding and there's taking pride of what we have done. But in terms of that we needed to, just the same thing, we talk about HIV. HIV for the longest time has been donor funded. Until the point when that started reducing and the threat of it coming to an end, and some programs now starting getting affected, like the blood transfusion services programs and such. That's when it starts becoming an issue to even the leadership and the legislators. But how can we get ahead of that?
They say that for research to be effective, there has to be trust. And for this trust to be earned, then it has to, the research in itself has to be community, localized into the community. The community must understand why the research is being done. They must understand that these researches that are being done are ethical, and they will actually mitigate on public issues or public health matters that affect them.
Yeah.
So in that prospect, if the community gets empowered to understand this research and the value of it, then now I believe the political leaders, to my understanding, will now be forced to actually see the value of it and see the need to start allocating and discussing it. So more conversation on it, more conversation on research, more conversation on the outcomes and the mitigation that it puts forth need to really continue. I need to be there.
Let's take a break. We'll continue the conversation. Dr. Davji Atellah is the National Secretary General. Is it General Secretary, Secretary General You guys keep switching these things every time. The National Secretary General of Kenya Medical Practitioners, Pharmacists and Dentists Union. We are talking about the place of research in the country in tackling future pandemics.
This is the Situation Room, the only way to start your day.
Siti, ask your question to Daktari.
As a union,
Yes.
what role do you see yourselves playing in advancing this discussion about research and its importance, not just in the medical field, but in all spheres of our lives? Because unions are activists. They push agendas that other people are not willing to push. And your particular union is a union of healthcare providers. So, if we do not prioritize research within our institutions, within the government, and go beyond just Kenya Medical Research Institute, and still rely on donor funding, and yet that donor funding we speak of, a lot of it has to do with money that their government has put aside for research, their governments. Where do you people fit in? And how do you change the situation so that our government is more responsive to this and that we own this process so that it becomes ours and this over-dependence on donor money is reduced over time?
Yeah, I think that's why we have begun this conversation, because we want an ultimate deliberate investment of both the national government and the county government and even the parastatals into a real research over the things that are taking place in the hospitals. And over time, we have seen many breakthroughs, procedures being put in place in different facilities in the country, where first aid surgery, first surgery on this part, in most of these level 5s, level 6 are doing that. But we have not seen any clear new discoveries that these hospitals, national teaching referral hospitals are putting up, or the universities are working on to put up. And this is clearly because of lack of support or government policies that are encouraging these researches to take place. Because members of the medical colleges, members of the doctors are working in all these facilities, are members of the union. We find that there's need to really have mixed skills in these facilities, mixed skills in these institutions, so that we do not normalize things that can actually be prevented. We have looked into the benefits that research has put up in different spheres of medicine, even into the mitigations of outbreaks that will be there. So then, if we have a data whereby the labs that are being requested in parts of the country are not just limited to that, but they're limited to further into investigations on what patterns, what disease patterns, trend can be prevented, and this will essentially improve the medical service delivery in the country. That's why we have taken this approach to really empower and make this collaboration be part and parcel of the community and of the political class.
Can you give us even as we're having that, I mean, it would seem obvious if one was asking the question, but make the link between proper developed research and disease prevention or management. Can you show, because we could be here and it seems as okay, we're insisting on research, and then we've not been able to make the link between how well researched some of these medical interventions can be and what can actually be done as a result of it. Because folks might be saying, okay, so we're looking under a microscope and then somebody has malaria, so what? What's the link?
When you do research and when you have data of a disease, it makes you to know that in this particular scenario, we have this particular strain of a virus that can make you predict the particular the drugs or the vaccines that need to be developed. Let me give you an example of what happened in Congo, where there was the Ebola virus. Once there was an outbreak the first time, there's one doctor at the team that took into research, and within a period, there was now a vaccine that could actually mitigate on the Ebola, the Congo type of Ebola virus that prevents actually the another outbreak. We now have another strain of Sudan type of virus in Uganda, which do not have the vaccine. So based on the previous activities or the research work, it's easier to predict or to predict that there will be another strain that will be coming. And based on research, you can actually make vaccines immediately it comes in, so that the fatalities that will occur are prevented. This also is what happened in the COVID-19. There was data of particular pathogens, corona type group of viruses that were already marked. So when we had the outbreak, it was not starting from a stand zero. It was starting from there's a part that the researchers were starting from, and that made them to have the vaccine within a period of 1 year. Normally, it will take 15 years to 20 years to have a vaccine that has gone through all the clinical, preclinical and clinical trials to be in the use in the market. But this took a very short time based on the existing research that had been there. And that's why we are saying, for this to help not only in the countries that are in the global north, then we have in our African countries also take research seriously, so that we can see surveillance, we can continue with surveillances and identify any pathogens or any that is noticed earlier, because that communication or sharing of the knowledge will help in earlier action. Yes.
There's a question that has been on my mind for some time. The vaccines that we're using for COVID were on a trial basis, okay? The efficacy studies that are required for a much larger population, again, remember the issue mentioned at the beginning where scientists in, say, France said we should conduct some of the clinical trials here. Now, most people think that when you conduct clinical trials, essentially you're using Africans as guinea pigs. And that's the issue. Okay. Of the vaccines that were approved for use on a trial basis, how many of them have since been approved? How many of them you can now say, okay, this one, it went beyond that stage, now it's been approved? There are those that the FDA has approved. And if the vaccine is still at that stage where we say it is trial, should people still continue using it?
There's one thing in the medical field that is always looked at when we are doing the research, that they look at the risk versus the benefits that is there. For example, if there is a disease outbreak and we have drugs or vaccines that are on trial, but there is a probability that using these particular the drug will prevent this disease or have more benefits than the risk that comes out of the toxicity, then that always is being used. That means the benefit that it has outweighs the risk of it. But when you come to this part of the vaccines that were rolled out, one important thing is that there's need to have that understanding of the reason. Why was this? Why was there a hurry to have the vaccines being released before the full clinical trial? It was because of the efficacy that had already been demonstrated with the few that had already been in market. There was a clear cut that there was an 100% prevention of death. The benefit that if you get the vaccines, you're not going to die out of this virus, but you can still get the disease. So that mortality benefit that accrued from it made many of the countries actually approve its usage. We have had more than, I think, 8 different companies that got vaccines that were on trial that then became now approved to work. So that alone was a very positive aspect on the research that was ongoing on the vaccine. And this happened because of the network, the research network of both countries. That's why even when you got a new strain in South Africa, it was quickly shared, and different countries were trying to get, does these vaccines work on this particular strain? Because that sharing of knowledge then helps to get an action on the virus. Yes.
Okay, how should it look? How should it be? If we were to paint a picture of what the research and development arm of, looking at health in the country, what should it look like? And are we currently saying that because political goodwill, I think, plays a huge role here. People have gone and we've made the Abuja declarations and et cetera, but then we've come back and still not been able to implement them. Now, whether we've still not been able to or have not been willing to are two totally different things. Is the health sector jostling for a piece of the budget cake and has not been able to get it? Or has it just not been top of mind for policymakers to say, this is how it ought to be? How should it look? with the resources that are currently available in country, is it possible to have a robust research and development arm in the health sector to get some of these things that we are looking for rolled out?
When you look at the health budget that most, I would say, developing country or African countries put is actually very low. We have an African Union agreement of 2001 that's 15% of the budget need to be to healthcare. But if you look at our country in the year 2022, 2023, the budget was 4%, meaning even the elemental aspect of the human resource for healthcare that we need to have the personnel working in the hospitals can't be covered. The aspect of having the drugs, the aspect of having equipment can't be covered with that budget. So that's why if you look at that budget that is there for the research component, you'll get less than 1% put up, which essentially cannot run the research that is expected. And that's why there's over-reliance on the donors. And when donors give you money for research, they need the information. They need the data. The data is for them. It's now for you, the country now, to beg for that particular data that has been mined from the population. And that's why for you to really be part of the conversation, and this is something that we've been discussing, that is the decolonizations of the global healthcare, then the African countries like Kenya must also put aside some funds into this particular pool of research, not just depending on what the donors will give and then dictate, because the donors will dictate what they want and their interest in the money that are given for that research.
But surely some of these positions can be negotiated, because if a research project is a multi-site study, it means the developers of that research understood the need for that diversity, and that if it's medical research, if it's a clinical trial and it's being conducted among the people of, say, a certain country, there's something here that is a subject of debate. I don't think it'll end soon, because unfortunately, research projects that involve human subjects are conducted among poor people on this continent. Yes, it is. People who are probably most at risk. They're the ones who face this thing perhaps greater. Now, why do I mention this? I mention this because there are benefits to be derived, yes, but in the absence of that research being conducted, those who are funding it would not get all the information they need. So that participation should be adequate equity, meaning whatever data we are collecting, we also should have a say.
Yes.
Because we participated in your getting the data. So I'm asking the negotiation aspect of it, where when it comes to talking about who is in charge and who has first say on the data.
Who holds the data? Are you talking about data collected within country or data in a particular research where it's multi-country?
Whichever country is involved in that particular study, I'm saying should have a big say on that. Yes,
I think we were given that, we had that conversation in Kilifi, right?
We did.
And where now, because we have data protection laws with the country and a data commissioner in the country, now the law says that data must be
nestled here. So all the information that you gather must be nestled here. The server must be here. And then that means that you can have that discussion.
That you own the data.
Yes.
Yeah. But prior to
these
laws, there were no regulations on it, and it's actually the government had to really look for that information.
You see why I'm saying this is you may have that law, but how do you enforce it and how do you ensure it actually works?
Yeah.
Because when you have an MOU, when you have a proposal, when you have a document that binds you to the details of that research process, the people who are involved in it and institutions that are involved, how do we ensure that letter of the law is adhered to and that they don't sell themselves and their people short?
How about then that, remember the approval process?
Yes.
The custodians, the local approvers,
yes,
must ensure that
the ethical
that's what
review
they're
board.
For. Yes.
They
must ensure that this is part of the clauses that are there.
Yes.
The ownership of the data collected.
Yes, it is.
So the onus is now on the ethical review board.
It is. You see, the beauty of that is when looking at the ethical aspects of data. Why I'm talking about the ownership and the discussion and negotiation aspect, you see, it should go beyond just data. It should go beyond to the point of the welfare of the participants, the welfare of the communities that they come from, and not the benefit that research promises in the future. That is all good and well. But the benefit that they derive, because without them, the information that you're going to bring that future with will not exist. Part of that negotiation. So when they're looking at these proposals, that is a consideration. I'm sure they look at it, but I'm saying the emphasis can never be enough.
Yeah. I want to go back again to the issue of the current platform that gathers data. Okay, because I think when it comes to research, if this was very well managed, the current Kenya Health Data, what's it called? Kenya Health Information Services. The Kenya Health Information Services, if it was properly managed, then the bottom line and the main baseline surveys for information would be easily accessible. It sounds, and it from very many people who talk about this, is yes, there is collection of data, but it's not very well coordinated, that this is the kind of information that gets into it, that this is the person who checks the data to make sure that the data is current and that we are collecting data regularly. Then who is reviewing the data, who is interpreting the data, who is passing it on, who's categorizing the kind of information that we're receiving, so that today you're saying we want to find out whether the incidences that we are seeing of a particular, let's say like what we saw them doing in Kemri, Kilifi, they are talking about epilepsy and mental health.
Yeah.
If there was data that shows mental health and there is data that shows epilepsy, then just from collecting of that data that's already there, that already take you like 100 steps ahead.
It does.
And then now you start working from the data that we have. How about if we fine tune, go into a community and then know what kind of information you're looking for? Because it sounded to me like the Kilifi guys have to go to the ground and start collecting data from scratch.
Yes.
Yet we have health facilities that are interconnected.
By
And
the
have
way,
records.
You see, that's the point.
Yeah, and have records.
Data is collected every day in health facilities.
Yeah.
Every single day. Now the question is, what do we do?
How
with
does
that
it-
data?
And this is the thing for me, that it seems as though there's a duplicity of effort. Is there another word after duplicity? There's a duplicity of effort because you're collecting all this information. You have this rich mine of information, of records back and forth. Anybody who walks into hospital is potentially somebody with some history, is somebody with some information that can then be used for tomorrow. But then something happens and then we want to start from the beginning. And I'm wondering why is that? Do we not realize the rich resource that lies within our health facilities? Amongst health practitioners, amongst community health workers who know communities more than anything. When we're looking at mapping, for example, that was one of the big problems at the initial stages of COVID-19. And folks were saying, well, okay, it might be difficult for us to trace whomever. These are people who've walked into hospital, and the very thing that you do when you walk into hospital at before you get to the triage is you write your information down.
Yeah.
Isn't it? But then here we are again saying, okay, well, somebody who's walked into hospital, we have to then go again and find out where they live. Come on, it's right there. You have it. So what it seems to be a disconnect between the two. If we're talking about a future pandemic, are we going to start from the beginning again?
Remember when Dr. Luga was here, he explained something that they have done with the health services in this county. And he mentioned the word community unit. Then he talked about healthcare workers.
Yes.
And the thousands, not hundreds, that they had employed. Now, if you do not have these people, if you have that information, that follow-up will not work.
And actually, that's what is happening in many of the parts in the facilities in the country. And what we say is that if even Kemri was integrated with the counties and the ministry, to the point that we have research units in every part of the country, level 5 hospitals, level 4s, level 3s, so that even the disease trends, the treatments that are being done, actually recorded and form part of the research. And the research officers that are actually employed to mine and to have this data, then we'll have a different way of managing the diseases. But as we speak, that does not exist. The data, yes, is filled in the data, yes, and it remains there as for demographics, but then even when there are trainings or teaching in the universities, the data that I still use or the trends I still use are for what has been done in the Western countries. In Europe and in the United States, those are the studies that are being used. But we have not gone down to ensure that we have research units in level 5 hospitals, in level 6 hospitals, and actually the personnel who work now with these specialists and the doctors that are employed there. And that's one thing that even if you look at the budgeting that is there within the counties, that aspect is not there, meaning that it has been overruled. So it really needs more emphasis on its value and outcomes to make it part of the process of the counties and nationally. Nationally,
the job of the Ministry of Health is policy, and of course, it's in charge of all this. It's in charge of data. It's in charge of research. It's in charge of all this work that needs to be done. And question that we keep asking, I keep asking here. So, with the kind of money that they receive and the work that they have to do they all need to be here, or should they be seconded to regions and counties so that then there's better coordination? Because I get a feeling that, when people are sitting in Nairobi, they just have a global view, and as long as information is coming, well, we've got information. We are receiving a lot of information.
Actually,
do you know from how many centers?
Actually, health is a shared function between the counties and the national government. And we have all these projects and programs, even KMPDU, running at the national government. And it is a fact that the way the counties are running, which they try to act as autonomous from the Ministry of Health, if a framework is not conceptualized between the incoming CS and the Council of Governors and the governors, then we still have that gap in existence. But they need to know that you cannot say this is part of county, this is part of national, when we are all Kenyans and we need the benefits. So that's one thing that has to be looked into. How do we ensure that now these policies that have been made by the Ministry of Health are implemented in the counties? I will tell you that the policies are good. They will be the many that are being made every day, but the implementation in the county is almost zero. The same way to the research that are done with KMPDU and this aspect. There was even a data that came out recently from KMPDU on just human resource, the staffing, the gaps that exist in the counties, where level 4 is level 5, which ought to offer services, intensive care services, theatre services, the number of personnel they need to have are not in existence. But that data remained at KMPDU. It's not being discussed in any of these counties. Therefore, there's no way it can be implemented.
So how do you make that happen? How do you move it?
So that's why there's need to be a deliberate way to have counties and the ministry have an enforcement framework. Because even now, decisions that are made even with PSC, that are made even with any of these commissions, the counties can choose to ignore, because they claim some autonomy on the operation, like a different country. So if that is not changed, then we are going. That's why we have a lot of gaps in healthcare. The reality, if you go down into these hospitals, there are many deaths and many severe conditions that will otherwise be prevented if there's a pattern that has been considered on them. Research, you see, look at the maternal mortality that's in existence, the number of gynecologists are needed, the number of medical officers are needed, and those are employed. We will have many of these that's prevented. But since that is not there, and there's a lot of, when such things happen, it's being hidden, they're being covered. And probably the patients are not empowered to speak out. A few really speak out. But when many of them speak up, then is when the counties and the government react to the issues. Then that's what actually happens.
And they only react to put off the fires, not to address the long-standing issue. Because the governor is also just playing politics. And he's playing a five-year cycle kind of politics. I mean, are people coming to the hospital closer to the election? Make sure that people come to the hospital and get all the things that they require. After that, forget about it. We need to continue having this conversation about health, whether we renationalize it or whether we just tell governors, you know what, you guys just deal with building hospitals.
Like today we saw in Ahero, the made to close one of the wards, male wards. And the reason why that ward is closed because there are no personnel.
What?
It means that there are no doctors, there are no nurses, they can provide services.
serve.
But to see what information that the counties have is that they have enough staff. And I will tell you, for the last 5 years, it is the first time we're having a country where the doctors are graduating, doing internship, and they're not getting employed. And
there's a need at the
and
council.
there's a need.
Same with
There's
the
a
other
big
health-
shortage.
Same with the other healthcare
and
providers.
all other healthcare workers. Yes.
Anyway, Daktari, we thank you very much. Always welcome to come and let's have these conversations. The seat that you occupy, it's important that you have this kind of national platform, talk about these issues so that you can push advocacy for healthcare.
Thank you.
Dr. Davji Atellah is a Secretary General, National Secretary General, and the CEO of the Kenya Medical Practitioners and Pharmacists and Dentists
Board.
Union.